Okay. So, a very good evening, everyone, respected faculty and distinguished delegates. So, on behalf of the entire Gennova team, I, Dr. Supriya Pol, currently working as a medical lead in CNS cluster at Gennova, welcome you all to this first stroke interventions stories workshop. Well, this initiative has been thoughtfully designed to provide an interventional neurology perspective on stroke care with focused attention on key clinical challenges and decision points. So we are very confident that these sessions will provide a very meaningful clinical perspective and actionable takeaways that can be translated into everyday practice. So with that note, it is my absolute honor to introduce our today's distinguished faculty. So first, we have Dr. Anand Alurkar sir for today as a course coordinator. Sir is an interventional neurologist and stroke specialist, currently working as a head in KM Hospital and Jahangir Hospital, Pune. Well, sir is highly experienced interventional neurologist with more than 20 years in stroke and neurovascular intervention. He is among the first few pioneers in this space in India, Pune. Sir is also expertise in endovascular treatment of ischemic and hemorrhagic stroke, including thrombectomy, stenting, and aneurysm coiling. Well, to highlight few of the sir's last 20 years work, sir has done more than 9,000 plus diagnostic cerebral angiographies, more than 3,700 major neurointervention. Sir was among the first in India to deploy a MCA stent for recurrent stroke way back in 2004. Sir has a high volume experience in intracranial stenting in India. He is also a founder secretary of Society of Neurovascular Intervention and also an executive committee member and past president-elect of ISA. We welcome you, sir. So moving on,
thank you,
we have Dr. Shripal Shah sir joined us today as a moderator. Sir is an intervention neurologist and also a stroke specialist and currently working as a head neurology in Shadri Super Specialty Hospital, Nasik. Well, sir also comes with a wide 15 plus years of experience in comprehensive stroke care and neurovascular intervention. Sir is a pioneer in establishing advanced stroke and neurointervention service in North Maharashtra. Sir is also expertise in mechanical thrombectomy, cerebral angiography, stenting, and aneurysm coiling. Sir is a proven leader in building stroke system with multidisciplinary teams and improving the patient outcomes. Sir has been invited as a faculty in both national and international and active contributor to the stroke education and research. To highlight a few sir's work in last 15 years, sir has done more than 5,000 plus cerebral angiographies, 125 plus thrombectomies, 200 plus carotid stenting, aneurysm coiling, intracranial stenting, executive committee member of ISA and also of SNVI. And sir is a member of leading global neurology and stroke organization. We welcome you, sir.
Thanks a lot, Supriya.
Moving on, we have Dr. Pradyumna sir as a moderator. Well, sir is a director and head in the Department of Neurology of Navnati Max Super Specialty Hospital, Mumbai. Well, sir is a very senior neurologist with more than 20 years of experience in interventional neurology and stroke care. He is a pioneer in advancing acute stroke care and neurointervention practices in India. Also expertise in management of acute stroke, aneurysm, carotid and intracranial stenosis, and AV malformation. Sir has an extensive experience in interventional neurology, procedures including stenting and endovascular therapies. Sir is very active academicians involving in teaching, research and development of stroke units. A few key highlights: Sir is director, head neurology at leading super specialty hospital in Mumbai. He is also a founder member of Society of Neurovascular Intervention. He is an advisory board member at SNBI and proctor of Global Neurointerventional Technology. Sir is also published research in leading journal including stroke and very recognized among top doctors in India for neurointervention. We welcome you, sir. Moving on, we have Dr. Vishal Gaikwad sir as a speaker for today's session. He is working as a consultant at Care Sigma Hospital, Sambhaji Nagar. He's trained at prestigious KM Hospital, Mumbai. Sir has completed MD in General Medicine and DM in Neurology. Sir has finished his fellowship in Interventional Neurology from Nanavati Max Hospital under Dr. Pradyumna sir. He is also observership in Advanced Neurointervention under Dr. Anand sir. He has also been awarded FINR Gold Medal in Interventional Neurology Exit at SNVCon, Delhi. Sir is also expertise in stroke intervention and endovascular neurological procedure. A few key highlights. Sir has a very strong academic background from premier institutes. He has advanced training in interventional neurology and stroke care. He is recognized for his excellence with national level FINR gold medal and currently practicing as consultant interventional neurologist in Sambhajinagar. We welcome you, sir.
Thank you.
At last, we have Dr. Mukesh N. Sharma, sir, as our second speaker. Sir is director at Marengaon Sims Hospital, Ahmedabad. Sir is highly skilled interventional neurologist with more than 10 years of experience in neurointervention. He is among the first few neurologists trained as an interventional neurologist in Gujarat. His expertise in comprehensive stroke care, including thrombolysis and mechanical thrombectomy, advanced proficiency in DSA, intracranial stenting, and acute stroke intervention. Sir also brings in a lot of experience in aneurysm coiling, flow diverters, and AVMB embolization. A few key highlights. Sir is expertise in stroke intervention and neurovascular procedures, specialize in carotid angioplasty and stenting, and also leading neurointervention service at Premier Institute in Ahmedabad. We welcome you, sir. So with this introduction, now I hand over our session to Dr. Anand, sir, to set up the context for today's session. Over to you, sir.
Yeah, thank you very much, Dr. Supriya. I am very honored to be coordinating this course. This is an excellent venture on the part of Gennova. And I think you're already doing this for stroke in general. And we always used to think that it is high time that Gennova also participates in promoting neurointervention. So this is an excellent venture on your part. And I hope this continues program, this venture continues for probably many, many years to come. And we are always fond of teaching. We are always fond of sharing our expertise and our problems that we have so that others learn from them. And this is an excellent platform for that. So I think I'll hand over to the moderators and then we can have the case presentations.
Shipal, sir?
Yeah. Good evening, everyone. So I think it is already near to 8:40 and everyone is interested to just start the ball rolling. So I think I'll ask Dr. Vishal Gaikwad to present his first case. And I think he will... Vishal, you are ready?
Yes, sir. Ready, sir.
Yeah. Okay. So you can share your slides and please present your case.
Is it visible, sir?
Yes, sir, it is visible. Okay.
Vishal, can you enlarge?
Yes, sir.
You have shared the slide. Can you enlarge it? Or is it visible to everyone? Okay.
Is it visible properly?
Yes.
Okay. So I'll just start the case. First of all, good evening to everyone. Myself, Dr. Vishal Gaikwad. I work as a consultant interventional neurologist in Sambhajinagar. So let us start with the case. So my patient is a 50-year-old female who presented with acute onset left hemiparesis and presented to me early in the morning, 8 a.m. In the morning. It started 8 a.m. in the morning. There were no past comorbidities and patient presented within 45 minutes of the stroke. So when I attended the patient in casualty, the power was 0/5 in left upper limb and lower limb. The presentation, on presentation, her NIHSS was 14, BP was 130/80, BSL was 128. So as a protocol in our center, we directly go for MRI brain stroke protocol. So in MRI brain, there was hyperacute infarct in right coronary data plus basal ganglia and flare was absolutely normal. And MRI was showing complete thrombotic occlusion of right M1 of MCA. So these are the images. So as you can see in DWI, there are just subtle changes in coronary data and in basal ganglia. And on the right side, right M1 is completely occluded, rest angiopart is normal. So as patient presented very early in the early onset, just 45 minutes. So option of bridging with TNK followed by SOSMT versus direct MT was explained to relatives because it was a large vessel occlusion and the stroke was of early onset, just 45 minutes. So bridging option was also given to the patient. Explained everything regarding bridging as well as direct MT. But relatives chose TNK lysis first. So patient was lysed with TNK 0.25 mg per kg dose. Post lysis, BP was maintained strictly between 120 to 130 systolic. After 25 to 20 to 25 minutes, patient improved almost dramatically to a power of 4 plus by 5, and NIHSS dropped within half an hour to just 3. So I was happy, relatives were more happy, but there is always but. After 1.5 to 2 hours, the re-deterioration started, and patient her NIHSS dropped to 10. So repeat MRI was planned. DWI was more or less same before. Patient was not having any headache or something or any hemorrhage sign. So DWI was more or less same, but this was the angio. So looking at angio, I felt that it could be either presence of ICAD in that particular region. The thrombus was lysed, and that's why there was the good recovery. And again, patient re-deteriorated because again the artery must have re-occluded, or second, there could be partial recanalization. So I went inside. I explained patient that MT will be definitely needed, and SOS stenting was also explained to the patient. So when I went inside, this was the DSA. There was complete thrombotic occlusion again of right M1 of MCA, but MCA territory was filling beautifully through right ACA via pile collaterals. So I formulated a plan of MT, and these were the hardware used. So Neuron Max as a guide catheter, RAID 62 for aspiration, Phenom 21 solitaire stent retriever of 4x40, Traxxas wire and penumbra suction pumps were used. And Solumbra technique was used for aspiration for thrombectomy. And in first pass, there was complete recanalization. So basically, that was not ICAD, that was just thrombus. And probably post lysis, there was partial lysis of the thrombus, and it was appearing as if it's a ICAD. So in first pass, there was TK3 recanalization. And this was the CT after 24 hours. As you can see, there is a small hypodensity in basal ganglia region. And in terms of clinical improvement, post-op status, after 24 hours, her power was 4 plus by 5, NHSS was 2 after 24 hours, and she is still coming to follow up with MRS 0 to me. So what are the advantages of bridging and what are the disadvantages of bridging when we do it? So first of all, bridging is definitely excellent for all those centers where drip and ship model is followed. In all secondary hospitals where MT facility is not directly available, then bridging is definitely a better option. It may dissolve small distal microemboli after MT. But what are the disadvantages? First, it increases door to groin time. Specifically, if you are working in a MT ready centers, it increases chances of reperfusion hemorrhage. Third, there could be partial lysis, which we have seen very frequently, that there could be partial lysis of those clots, and this fragmented thrombi may go distally, and your result, which could have been TK3, maybe would be TK2A or TK2B. So it also increases the risk of femoral hematoma. Altiplase will be an additional cost to it, but it could be excellent for centers with readily available MT facilities. So there are multiple trials on this. One of the trial is a direct MT trial. So this trial was performed in China in 2020. The objective was to evaluate endovascular thrombectomy with or without IV altiplase in patients of ischemic stroke who presents within 4.5 hours. And the conclusion was that it is non-inferior, that the endovascular therapy alone is non-inferior to the altiplase plus endovascular therapy. There are other trials also like DVT trial, SWIFT direct trial, Mr. Clean no IV trial. So all these trials more or less supports the notion that it is either non-inferior or it is neither superior nor inferior. But then there was a meta-analysis. This is an individual participant data meta-analysis of 6 randomized trials. Now, this trial did not establish a non-inferiority of endovascular treatment alone as compared with intravenous thrombolysis plus endovascular treatment in these patients. But it has neither proved superiority of the additional IV altiplase. So again, it's an individualized thing. So my take-home message would be bridging is excellent strategy for drip and ship model hospitals for sure. Chances of reperfusion is 18% with lysis in LVO cases, with additional risk of reperfusion hemorrhage and partial lysis of clot. So in empty ready hospitals, probably direct empty option should be individually decided, like this individual. So it's your own option or like this. Thank you.
Thank you, Vishal.
Do we have SWI image when the patient presented?
Yes, sir. SWI. Not with me right now, sir.
Because SWI will help us to
Yes, sir.
understand
Yes,
whether
sir.
it's a thrombus or whether it's a stenotic lesion.
Agree, sir. Agree, sir. Yeah. If you can see direct clot on GRE or DWI, it's a indication that it's a thrombus. Agree, sir.
And also flare will also help us to understand whether patient has an ICAD, because we can see some old watershed infarcts if a patient has an ICAD which go unnoticed. So flare
Yes,
also
sir.
helps us to understand. So
Yes, sir.
what we generally do is if a patient is in the window, even for thrombolysis, IV thrombolysis, if we see watershed infarcts or if we think that it's not blooming and so on, the history looks like it's stuttering, looks like ICAD, then in such patients we don't prefer giving IV thrombolysis, because if this patient requires rescue stenting, then it becomes a mess, because then
Yes,
we have
sir.
to know the patient with Torofluban. So as you said, it's very individual decision based on patient's history and MRI findings. That's what I think.
Agree, sir. Agree, sir. Thank you, sir.
Most of the time, GRE and SWI images will help us sometimes to find the clot also, MCA dense sign, which may be seen. But even the length of the clot also can be determined on SWI in the MCA. So that helps us to understand that thrombolysis is going to be futile or it is going to help. So directly these patients can be taken for the thrombectomy if the length of the clot is high.
Yes, sir.
Yeah.
But
That is also one indicator.
That is only true for soft thrombus. It
Yeah.
is not completely true for the heart or white plaque, a white thrombus if it is going up. Same is for the CT. If in a CT, hyperdense sign suggestive of a soft thrombus is there. If it is a isodense, okay, or if it is not showing in a GRE, it's maybe fibrin-rich plaque that may be there. It most of the time it is sole our problem is ICAD or is a thrombus, but sometime if white thrombus is there, it may not.
I would like to say a couple of things. Vishal mentioned about individualizing the decision. Now, this is very important. And this is a message to any neurologists who might be treating stroke, who might be attending this session. So one should not be very dogmatic about it. I have seen patients coming into the hospital, very high NIH stroke, LVO immediately seen on the angiographic study. The interventionist is available, the cath lab is available, and the patient is first given, the interventionist is not even involved in the decision making. The patient is first given IV thrombolysis. Even today in this age, in 2026, I have seen neurophysicians waiting for recovery after IV thrombolysis. And after 1 or 2 hours, if there is no recovery, then calling the interventionist, etc. And the interventionist is saying that I was here all the time. You could have called me 2 hours back. So, although sometimes we may think that this is so far away from whatever class 1 guidelines are there, but still these things are happening many times. So, if the interventionist is available, the cath lab availability is there, I think there is absolutely no role for IV thrombolysis. If within minutes or within minutes of the angiographic study, if the family is also willing, then directly the patient should be taken to the cath lab. In fact, we have a concept of direct to angio suite, where a recent trial has proven that in a DSS suite in the cath lab where CT scan facility is available, a high NHS patient can directly be taken to the cath lab, a CT scan done to rule out bleed, a DSA done to rule out LVO, and the procedure proceeds with a mechanical thrombectomy. So it saves a lot of time, effort, and definitely finances also. It bypasses a major sticking point, major step of going to the radiology department, getting the scan done and getting it reported, etc., etc. Yeah. Sagar, you have anything to add?
I mean, I completely agree with you. Direct to angio suite in where we have CT to rule out, it's an excellent thing to do, especially in high NHS and when patient is eligible for thrombectomy. Regarding the soft clot, if it is less than 8 millimeters on SWI and if it is blooming, then sometimes it may improve. But we have to, whatever cases we see that patient received IV thrombolysis and patient started walking and improved immediately, all said and done, the rate of recanalization is not more than 20% or 25% after giving IV thrombolysis. So it is definitely, it doesn't work in 80% of the patients, whereas first pass effect is almost close to 85% with all the hardware that we have now. So obviously, it's a no-brainer that mechanical thrombectomy is a way to go, especially in LVOs and high NHS patients.
Sir, can we take some questions from the audience or?
Yeah, is it possible?
Alpita, is there a way?
So the questions portal is already open, but there are no questions yet.
Okay.
So audience, I request you, if you have any questions, you can please type it in the chat box. Probably maybe we'll take it at the end of the session.
Okay.
Yes, if there are any questions, then I'll let you know. But till now, there are no questions.
So I think from the first case, what we conclude is, with all the experts' opinion, is any LVO with a clot which is less than 8 millimeter or more than 8 millimeter seen on CT or SWI and high NIHS direct angio suite, patient can be shifted and can undergo mechanical thrombectomy for the same. Chances of recanalization are 80 to 85%. And with IVT, it is less than 20 or up to 20 to 30% maximum. So I think we go to another, the next case, if everyone permits.
Yeah.
Yeah.
So have you got my slides, your video?
Yes, sir, we've got your video. RS events, I request you to please share the same.
So before starting my video, good evening, everybody. Thank you for this opportunity. So I'm going to talk about the golden hours. So whenever stroke treatments comes in the picture, we always just keep, don't play right now.
Pause the video for now. Let's complete.
So whenever we talk about the acute stroke management, the times comes in the picture. And you all know that every minute 1.9 million neurons are dying. Okay. And we have seen if patient treated on time in a golden hours, the recovery rate is quite high. So even IV thrombolysis, like if you do the IV thrombolysis within 90 minutes, the number needed to treat is around 4, which goes high to 9 if you are treating within 3 hours, and further up to 14 if you are treating, giving IV thrombolysis up to 4.5 hours. So time is a brain, and brain is a time. So the golden hour is a time after acute stroke onset. Okay. And if we can offer the treatment in the first hour, the recovery chances is quite high. And golden hours of acute stroke treatment is different. So once patient reaches to your emergency, clock starts. And the first 60 minutes in emergency actually call as a golden hours of acute stroke treatment. So that is for all patients from 1 hour to 24 hours reaching in your emergency. So that can be delivered, that kind of the treatment like IV thrombolysis or a thrombectomy can be delivered on time if you are investigating the patient within a limited time frame. So we have made a video for how we are treating acute stroke, patient reaching in our hospital in emergency. Can you play the video? In a real scenario. Sorry, my we all know acute stroke treatment is a time-based treatment. So we offer IV thrombolysis up to 4.5 hours of stroke onset. Up to 24 hours we can offer mechanical thrombectomy. And to deliver this treatment, we need a fixed protocol in our hospital. So any patient who are reaching to our emergency, they follow fixed pathway. In this video, we are going to show you how we are treating acute ischemic stroke in our hospital, in our emergency. Once the patient enters in our emergency, the clock starts. We have to do certain investigation within time frame and deliver the treatment within time frame.
So the patient is having stroke with right-sided hemiplegia and motor aphasia. Her pulse is 87, her BP is 120/80 and her blood sugar is 237. I would like to announce code white.
Good. Emergency department plays a significant role in stroke management. Our care begins at pre-hospital level. On receiving the patient in emergency, we rule out life-threatening condition and then go ahead with the history and physical examination of the patients. On suspected stroke, we activate code white to minimize the time interval between different investigations and get the treatment as soon as possible for the stroke patients. We rule out stroke mimics and activate the code white and shift the patient for neuroimaging. Our aim is to deliver the stroke treatment as fast as possible.
Code white activated emergency department, bed number 24.02.
Code white.
There is an announcement going on.
Phase 3, ground floor, emergency department.
As well as for the stroke treatment.
Bed number 02.
This is a stroke team.
चलो हाथ ऊपर करो, हाथ दायां हाथ ऊपर करो, दायां पैर ऊपर करो, पैर ऊपर करो, पैर ये ठीक है, बोल नहीं सकती है.
So as the code white is announced, we neurology team arrive at the emergency room. We assess the patient. This 50-year-old lady is having right-sided upper limb and lower limb weakness along with speech difficulty. She is having aphasia. So we see her sugar, which is 125, and then we shift the patient to CT scan, and after CT scan we will plan for the further treatment.
एक पैथोलॉजी रिक्वेस्ट है जिसमें हम एक्यूट स्ट्रोक प्रोफाइल लेते हैं और जब भेजते हैं पैथोलॉजी में तब उसके ऊपर व्हाइट कलर का स्टिकर लगाते हैं जिसमें विद इन हाफ आवर्स में हमको रिपोर्ट मिल जाती है कोड व्हाइट की जो प्रोफाइल भेजते हैं उसकी.
Patient has acute stroke. We are shifting patient for emergency CT scan.
So meanwhile, patient is going to the CT scan or CT scan is done. Our resident takes the complete history and explain about the IV thrombolysis. So once the CT scan is done, we offer the treatment or we can start the IV thrombolysis just after the CT scan.
CT head showing hyperdense ICA and proximal MCA with hypodense insula showing high aspect of 9.
Emergency CT scan is done. Patient is out of window period for intravenous thrombolysis. Hence, we are shifting patient to cath lab for mechanical thrombolysis.
This patient is out of the window period, but suppose some patient is in the IV window period. We deliver the IV thrombolysis either we are using the TPA or tenectap place. We are not waiting to get the effect of the IV thrombolysis. We directly shift the patient, particularly those patients who are having the large vessel occlusion, to the cath lab. So now patient is entered in the cath lab, and our staff is preparing the patient for the thrombectomy. During that time, I have certain minutes to discuss with the relative. Financial part is very, very important, but in our hospital, we don't need to take a financial clearance before the MT. So this relative, they have to sign up. They are going to deposit the money during the hospital stay or while leaving the hospital. So no need to clear before the procedure.
देखिए इनको क्या हुआ है कि इनको ब्रेन की लेफ्ट साइड की नली ब्लॉक हो गई है. इनको हार्ट की बीमारी थी जिसकी वजह से क्लॉट निकलकर ब्रेन की नली में चला गया और हमारा जो लेफ्ट साइड ब्रेन है वो राइट साइड को कंट्रोल करता है. तो इनको खून ब्लड डिजोल्व करने की दवा नहीं दे सकती. 6 घंटे बाद में हम लोग इसको निकालेंगे, है ना, यहाँ के वायर से जाकर मदद से इस क्लॉट को निकाल देंगे. ठीक है, ओके. ICA occlusion. This is the ICA which was occluded, and with the thrombectomy we have opened up terminal ICA. You can see both ACA and MCA, and on table see improved. कैसे हो आप? बोलो. अच्छा, हाथ ऊपर करो, करो पूरा ऊपर करो, पूरा ऊपर करो, पूरा ऐसे करो. And you can see that clot which was removed from her MCA. And on table she started little bit speaking. Ram Ram. ठीक है अभी.
Now post MT patient is going to shift to the neuro ICU, where patient is going to be managed by neurologist, critical care guy, physiotherapist, and supporting staff.
और बोल पा रहे हो? हाँ. Okay. आपका नाम क्या है?
अंजय.
ऐसा से करो. कहाँ रहते हो आप?
पटना.
Post thrombolysis or thrombectomy, we monitor patient in ICU. Especially we monitor blood pressure monitoring and conscious level. If any change in conscious level or GCS, we give osmotherapy for raised ICP. We involve neurosurgical team, and if required, we provide mechanical ventilation support.
So as a neurology team, we see the patient for stroke-related complication. We also assess the etiology of the stroke, why the stroke has happened. And we decide antithrombotic therapy for secondary prophylaxis of the stroke to prevent the further stroke. And we involve physiotherapist as early as possible so that patient can be mobilized early. And we assess the swallowing. If it is impaired, then we also start speech and swallowing therapy.
So we have to do the CT scan within 25 minutes. We have to thrombolize the patient within 60 minutes. And we have to shift the patient to the cath lab if patient is having the large vessel occlusion stroke, and we have to open up the artery within 120 minutes. And to deliver this treatment, to complete this target, we have to go with the fast fixed protocol.
मैं यहाँ आई थी तो इस पैर पे और इस हाथ पे नहीं चल सकती थी और ये हाथ भी मेरा काम नहीं कर रहा था. डॉक्टर साहब ने देखा मैं ICU में ऑपरेशन किया. थोड़ी देर बाद मैं ठीक हो गई. तो बोल भी पा रही हूँ और कह भी पा रही हूँ.
This patient has improved within 72 hours from complete hemiplegia and motor aphasia to normalcy.
Sorry, I could not play my presentation. So just short video I sent for the presentation. Our protocol is fixed. No need to actually give the instruction to the emergency guy. Each and every stroke suspect go with the fixed protocol, and we have the CT-based protocol, number one. Only deviation from the CT-based protocol if we are suspecting a posterior circulation stroke, number one. If patient coming with a low INSS stroke, then, and third, wake up stroke. In the only three conditions, or patient presented with a hypoglycemia, or sometimes patient has a recovery from the onset, then only we deviate, we go with the MRI protocol. Otherwise, our imaging-based protocol is fixed. We give the thrombolytic treatment in almost all cases, and we are not waiting for the improvement. After the immediately IV thrombolysis, patient transfer to the cath lab for the thrombectomy, particularly in LVO or MVO.
It was a great presentation, Mukesh. And I would like to add that when we say that a particular hospital is a comprehensive stroke center, we should not just consider the presence of expertise and equipment, but also such a protocol which gets followed in each and every case, and where the timelines are studied, where we go back to the timelines and we see whether the time can be shortened in subsequent cases. So a replicable protocol, and which can also be improved. I think that is a very important criterion I feel when we say that a particular hospital has a comprehensive stroke center.
Absolutely. Like in the last sketch, which I did 4 or 5 days ago, where door to revascularization time was less than 60 minutes.
Yeah.
So that's the way we are doing. And now everybody knows actually what is the code white in the hospital, from doctors to the attendant. So that is a way we are treating acute stroke in our hospital.
How do you decide about anesthesia? Do you do your patient under conscious sedation, or?
No, 90% of the patient follow with the conscious sedation. Only 10% of the patient, those who are not cooperating, I am going for the anesthesia, otherwise not.
And patients who have received IV tenecteplase or alteplase, how many times have you seen recanalization when you shift the patient on table?
Our transfer time is very less. Okay, it's almost 10-15 minutes from emergency to the cath lab. So you hardly see. Hardly see, because the time from cath lab, emergency to cath lab is very like 10-15 minutes only.
That's great. That's amazing.
And in the last case we were discussing the previously, I have given, like we treated with the tenecteplase 15 milligram, then 5 milligram I given as an IV because there was a distal embolization. So like in the last choice 2 study, I think, where if you are not getting a good recanalization like a TK2B or 3, and if you think there is a partial recanalization or distal embolization, then intra-arterial thrombolysis actually help.
Mukesh bhai?
Yes.
I just wanted you to highlight everyone the importance of where we are getting delayed in the golden hours, where we can improve ourselves. For IV thrombolysis also, as you have shown in the video, but the major hurdles what we face, I think one is before the patient reaches the hospital, he doesn't understand he has a stroke. And to reach he is near to the window period which has been completed. Number one. Secondly, radiology is a biggest hurdle in most of the hospitals, because patient going outside, coming in, or inside the hospital also there is a delay. Third is the consent from the relatives, what we don't get immediately. And even if we get the consent, there are finances which has to be taken care of. So I think how you want to put it or summarize everything?
So the first coming with the golden hours. So golden hours of acute stroke is a different than golden hours of acute stroke treatment is a different. Okay.
Right.
First hour of the disease is the golden hours, and first hour of treatment is the once the patient reaches to their emergency door. That start. Okay.
Right.
So we have the control on the second one. We don't have the control on the disease golden hours. So if you have the best time frame for the golden hour acute stroke treatment, you will get the best result, number one. Number two, about the radiology, if you have the fixed protocol, so you want to go with a MRI or a CT scan, then there is not be a delay, number two. And the second, in most of the corporate hospital, actually patient belongs to so many doctors actually. But in our hospital, patient belongs to anybody, neurosurgeon, physician, cardiologist, whatever the doctor. The radiology has to be done by emergency guide by the code white only. Okay, they want to inform me or not, that is a secondary part, but they have to go with a fixed protocol if there is a stroke suspect. There is no other way. So if you have the fixed protocol and your emergency doctors want to follow, then there should not be a delay. Now coming to the last part, that the consent depend on who are doing the neurointervention, how they are explaining actually, or they want to do or not, and they are flexible or not on financial part. So that is the actually art. You have to read the patient face, how financially they are good, and give the part like and better to, if they are slight delay or slight confusion, ask them for the DSA first, and I think that is cost least. Once you have done the DSA, if you're explaining this is the arteries occluded, the other side is completely normal, how the brain is getting the blood supply, hardly anybody will deny for the thrombectomy. That is my experience for last more than 15 years now.
Do we have any questions from the attendees in the chat box?
Yes, sir. There is one question.
Yeah.
So it says it is by Dr. Alok from Navi Mumbai. He says that why can't code white be activated at the time the patient is received? Ideally, it should be initiated even in the pre-hospital setting, page from the ambulance, so that the team is prepared before arrival. Also, is it necessary to wait for the neurologist to assess the patient in the ER prior to imaging? Could the ER physician perform the initial evaluation and proceed with shifting the patient for imaging when indicated? As in the video, it appeared that the activation and subsequent steps occurred after neurologist arrival, which might contribute to a delay in time to imaging.
No, it is first seen by the girl. She is an emergency doctor. She is not a neurologist. Okay, so it is seen by first the emergency doctor. She explained to the emergency in charge that this patient is having hemiplegia, and immediately code white generated. That code stroke team came later on, which is a neurologist actually, first the cable who came. So it is seen by that whenever emergency doctors suspect any stroke, they immediately announce the code white. They are not waiting for the stroke team or neurologist to reach to the emergency room. That is the number one. Number two, so there is another protocol for those who are coming the prior information. So this code white is announced before patient reach to the, as soon as they start with a in ambulance. Number two. Number three, there is a code white, another third one, that is for the in-house stroke patients. So if there is a stroke happen in-house, it is announced by the ward doctor, not by the emergency doctor. And emergency doctor they have to reach there to the particular ward to see the patient. So it is not limited to the emergency. For the code white for the emergency is a different than the in-house stroke. The code wise announcement is a different.
Okay, thank you so much, sir. So there is one more question by Dr. Suraj Jadhav from Nanded. What if there is a critical stenosis at M1?
For me, yes. If the critical stenosis and patient in an acute phase, and if we get the good flow after the removal of the thrombus, probably that is probably a culprit if it is. Then we wait, and may load with the antiplatelet if the infarct size is not big. Sometimes we give the tirofiban also, and let's see if the very good flow and TK2B or 3 flow, we wait. Otherwise, we do the small angioplasty and wait for 30 minutes. If it is not reoccluding, we just continue the medication. And if it is reoccluding, then rescue stenting, we can place a stent. This is about the acute part. Second scenario comes, patient having the minor stroke or TIA, improved, we load with antiplatelet and wait for a few weeks. If patient is okay, no further symptoms, we are not treating. If there is a further TIA or minor stroke, then after 3 weeks or 4 weeks, we want to place a stent. This is the usual protocol we are doing the actually we are managing. Am I right, sir?
Yeah, more or less. In certain acute stroke situations, actually, for example, if the patient is a known case of MCS stenosis, right? I think the person who asked the question meant that. But let us address that situation. Suppose the patient is a known case of MCS stenosis. He has been symptomatic in the past. He's had a couple of TIs in the past, and he's on dual antiplatelets, and now comes with a stroke, with a major stroke, LVO. He comes with MCA occlusion. So this is not a very uncommon situation. We do see such cases routinely, actually. So I feel in such cases, although there is no trial which has compared the two scenarios, I feel in such cases, instead of doing even clot extraction, instead of going for mechanical thrombectomy first, because the component of clot in such cases is very, very small. It is mainly the severe stenosis. It is mainly the plaque. So the component of clot is very small. So there is no point in even trying mechanical thrombectomy. We can go directly with intracranial stenting, especially if the patient is already on antiplatelets. I would strictly avoid giving any IV thrombolysis in such cases. And we have done cases we have not even considered removing the clot. You have just done intracranial stenting in such cases with very good results. Of course, there is no trial which has compared the two scenarios. It's very difficult to foresee a trial because this is not a very common scenario. But this is what we do with good results.
Thank you so much, sir. So there is one more question, if you allow. Actually, two more questions. First is the continuing question by Dr. Alok. Do we also need a page called stroke in all cases of altered sensorium where stroke could be one of the differential? Or in that case, so do we page it in all patients of AMS or examine and rethink?
Can you repeat the questions? Like all cases of unconsciousness patient, what that mean?
So he has just mentioned of AMS patients. So in that case, do we examine and rethink? Do you want me to repeat the question once?
Yes.
Yeah, I think so. Yeah.
So he mentions that do we also need a page code stroke in all cases of altered sensorium where stroke could be one of the differential? So do we page it in all patients of AMS or examine and rethink?
So stroke, the most important thing is sudden onset. If somebody is having a sudden onset LOC, definitely stroke comes in the picture. But somebody is having a progressive onset, a subacute onset of altered sensorium, then stroke is not in a differential diagnosis as a first, second, third. Okay. Then clinical examination comes in the picture, particularly in the posterior circulation stroke. There is step ladder pattern of stroke presentation, but the rest of they present in an acute sudden onset. So sudden neurological deficit, definitely there's two things only. One is the seizure, one is the stroke. Okay, no other differential diagnosis if the patient having a sudden neurological deficit in form of LOC.
Would you go for an MRI? Would you go for an MRI with such cases where you'll feel that an MRI will be better in such a case?
Because most of the time it's a posterior circulation stroke. If it is ischemic stroke, like in my talk also I told you that we follow with a fixed CT protocol. But whenever we suspect the posterior circulation stroke, whenever less than 6 NHS score or a stroke with wake up stroke, then we go with the MRI. Otherwise, our protocol is fixed for the CT. Because the posterior circulation stroke, you completely may miss on the CT scan.
Sure, sir. So there are two more questions. Do you want me to take it up?
Yeah, sure.
Yes, sir. So the next question is by Dr. Girish Vadgaonkar. He has first given a comment saying that 65 to 70% of ischemic cases are non-LVOs. And second, he has a question, within how much time the patient should reach the hospital with neurointerventionist from peripheral hospital. As the hospital in which he works in the periphery, the nearest interventionist is almost 3.5 hours away.
So yeah, definitely distance is a big factor, but real treatment in the rest of the world, particularly in the developed world, they do the thrombolysis as a deep and sieve the patient. So whatever the distance actually, so we have done the thrombectomy at 18 hours, 22 hours, even more than 20 hours, 24 hours, and patient improved. So no, definitely it's not all cases actually will be the candidate for the thrombectomy once they reached as the endovascular treatment site. But maybe the more than 50% of the patients still candidate for the thrombectomy or likely to improve with the thrombectomy. So in the periphery where the IV thrombolysis is only possible, after the IV thrombolysis, better to shift the patient nearby EVT center.
Sure, sir. Thank you. And lastly, we have a more from a generic perspective and from a future aspect perspective of how can AI help in stroke treatments. It's a very generalized question that has come up by Dr. Dattatreya.
So I think lots of hospitals are using rapid AI softwares. Am I audible?
Yeah.
Yeah.
Yes,
so
sir.
rapid AI softwares or other AI softwares are there where perfusion imaging are done, and through the software the data has been collected and immediately analyzed also. And these data were analyzed in most of the patients who were wake-up stroke beyond window period of 4.5 to 6 hours, and up to 24 hours they were using, and using the protocols of perfusion diffusion mismatch, or where these patients can be best helped for thrombectomies. So AI has definitely a role in acute stroke treatment, but there are lots of trials which have come right now, and which says that every patient of stroke also beyond window or 6 hours, perfusion may not be required in such scenarios. They can do diffusion flare mismatch, they can do clinico-radiological mismatch, and can be taken up for thrombectomies if so. Secondly, again, the drawback is the cost of AI generated softwares. They are very costly per year installments, and hospital has to bear, or the patient has to bear those costs. I think Mukesh sir, you may agree to it.
You are talking about the radiological AI based picture.
Yeah, radiological. He's asking radiological only initially in the patient care acute stroke management.
So one other model that is a hub and spoke model. Okay, so like we're discussing about the peripheral part. Okay, so if you're connected with the hub, all the peripheral center, so whatever the imaging is done at your center, that can be immediately transferred to the primary center, and that can be analyzed by the expert like a Sripal. Okay, and he may help you in making a decision about your patient. Patient require a thrombolysis or not, number one. Number two, this patient should be shifted or not. Number two, how much cost is involved, how much help you can do. So in a decision making also, even you are sitting on the peripheral center, that the expert, he can advise you, help you in making a decision how to thrombolyze patient in initial few patients and how to manage. So all these things can be done with AI models. Okay, if you're placing a BP and other vitals also, he can, like the expert can advise you what to do the next. So definitely AI is having a big role, starting from the peripheral to shifting to the central part, then analyzing the imaging. You can analyze your imaging, then you are putting your time frame also in AI model. So how your actually hospital is doing in that part. So everything, how you can improve by analyzing these your datas, where is the mistake, which part of a step is taking more time, so you can correct that part, so you can improve your quality actually in a stroke care. So definitely the AI is having a good use part, and probably right now, like Sripal said, it's a costly, but probably in a few years going to help is making the diagnosis, making the treatment plan, and then the follow-up. And again, in the physiotherapy also, AI model can help, particularly just some videos, and patient is just looking on those videos, doing a physiotherapy at their home. So in that part also, so definitely in a stroke care, from starting from diagnosis till the physiotherapy is a big scope actually.
Sure, sir. Thank you. I think that is all the questions that we had. Over to you, Sripal sir, Alok sir.
Sir, any comments?
Sagar, you have any closing comments to make? Dr. Oak?
Sagar is there or left?
No, I think he's left. Okay. Shripal, you would like to make some closing comments?
So I think it's a great podium for us to discuss most of the acute stroke dilemmas, gray areas, management issues, and share our own experiences plus guidelines, which can be used in tandem or hand to hand, and to help others also to treat in such emergency scenarios, all acute stroke patients. So I think it's a very good initiative, and we should continue this for a long period of time.
Yeah. One suggestion I would like to make to the Gennova team. I think we should take some feedback from the attendees who were present today, whether how we can improve the our format, or if they want any changes or improvements in the way we interact with them, etc. So that would help us in improving the future sessions.
Sure,
But
sir.
it was a great effort on your part, and I congratulate you.
Sure, sir.
Sure, sir. So again, on the behalf of the entire Gennova team, also I would like to extend my sincere thanks for trusting us with this initiative. That we could, have such an initiative with all the top neurointerventionists on board. And we assure you that going forward also, we will continue doing such sessions at regular intervals, and we'll keep having almost all interesting cases on board. And talking about the attendance, so we had almost 200 plus attendees with us for this very first session of SIS. So I think that itself speaks volumes about the success of this event. And we are sure that the attendance will only go above and beyond from here on. So thank you so much again for trusting us with this opportunity and for your valuable time. To all the speakers, Dr. Mukesh, Dr. Vishal, to our moderators, Dr. Shripal, Dr. Oak, and of course to our post director, Dr. Alukar. I'd like to thank all of you from the entire Gennova team. Thank you so much. And we assure you that we'll make all the necessary changes as per the feedback we receive, and we'll keep on improving the sessions here on. Thank you so much.
Thank you.
Yes, Kalpit, I would like to take a minute over here. Thank you so much, all the faculty doctors to join today, and thank you so much, Dr. Alurkar and Dr. Shipal sir, for encouraging us to start this new series on stroke intervention stories. As a Gennova team, sir, our motive is to treat each and every stroke patient, though it is thrombolysis, though it is intervention. But each and every stroke patient should get the proper treatment and should live their life longer. So, Doctor, I am thankful to all of you that you all are there in this noble cause and you are treating the patients very well, the stroke patients very well. Sir, we as a Gennova team, we promise you that we will be there to partner you in saving the stroke patients, and we will be there hand in hand with you, sir. So yes, thank you so much again, all the faculty doctors, all the members, and all the attendees to join the program. We will be continuing the series again month on month basis. And yes, about attendees, we have 234 attendees today, and I think this is the great number for the first program, I would say. So thank you so much, doctor, for giving this opportunity.